Anyway, I'm going to show two cases, but I think this is worth just pointing out the plaque analysis. Can you hear me still? So the plaque analysis, I know there's a lot of data and a lot of stuff, but I think for us as imagers in the room, we try to kind of help the ordering cardiologists. I think about 80% today are cardiologists by training. So what to do with the plaque analysis? So I think we're trying to kind of like come with a way to help the ordering folks. And I think remembering the plaque stage system, I think it's to some degree helpful. I argue that anytime you have significant plaque, in general, above 250, specifically for the young folks, and extensive, which is more than 750, it's worth mentioning that in the impression. And even some healthcare system will say maybe refer to preventive cardiology clinic to kind of take it to the next level. As you can see, those who are, treating cardiology patients, the LDL goals, the lipoprotein, some time, and more importantly, like the indication for adding other agents. So, you add ezetimibe to the statin for these moderates, PCSK9, even there's some role for colchicine, specifically with the FAI, the one I showed in the morning, with high pericoronary inflammation, you might add anti-inflammatory therapy. So try to kind of implement that in your impression if you have, and you will have more and more availability of the plaque analysis for your patients. So we're gonna switch gears now to cases. So this is a good case, and actually, faculty, I would like your opinion. At some point, we'll I think this is following what Dr. Lima has discussed about the CTFFR, just to kind of to put things together. So let's review this case together. So relatively young person, I believe mid-50s, came with outpatient referral for chest pain. So let's just window it properly. There is just following Dr. Lima's, he loves the MIP. I love the MIP for extra cardiac, extra coronary, but not the coronaries, but I will consider it. Here's the MIP. So let's go to 4 millimeter, 6 millimeter, and screening quickly through it. Left main, relatively short, trifurcate or even maybe bifurcate with a high OM. And there's something not right on the ostial proximal LAD. So this is something we're gonna pay attention to it. We come down, there's a focal lesion down in the mid LAD, gives a good size diagonal branch, comes down, then LAD tapers down. So it's not the largest LAD. So you expect to have a large PAD, and then the PDA, and then you have, actually there's some incidental finding. I might ask you later on to look at it. I just pointed out. But then let's look at the circ. Circ gives a large size OM, another OM, and then dies off. RCA so far, nothing really much impressive. We come down to the mid segment and down, down, down. So there's a questionable lesion in the LAD. So we go back to the MPR. So we're gonna go ahead and do that together. So again, the ostial LAD, proximal LAD was the interesting structure that I'm really concerned about. So here, so if you hold your Alt, keep it held, and then go with your mouse and click on it, it will take you to the lesion. From here, I try not to navigate except double obliquing, i.e. by rotating my cursor. So now let's double oblique the lesion, zoom in, back and forth to really open the lesion. So now you are truly at the lesion, and now I'm gonna go back and forth. I'm coming proximal to the end of the left main and start coming ostially. And here's the LAD. This is all like the beginning of the lesion ostially. This is some like mixed plaque between like the non-calcified and some positive remodeling and napkin ring. We'll get to it in a second. But if you go more a little bit distally, we're still in the proximal segment, and look how the artery narrows so much. So those in the room here, how would you grade this stenosis? Is it mild, moderate, possible moderate, let's say, versus severe? Okay, so I think, so this is moderate to severe, let's say. And honestly, this is the time when you have a distal segment that is not too far and it's really healthy. So if we go here, carry your cursor, this is a really healthy, relatively healthy segment. I can use it for my area. So from here, I'm just gonna fix this here. I'm getting an area of about 15 millimeters. So this is a large size LAD. This is a healthy segment. So now from here, I go back to the worst segments that I thought it was really tight. And again, double oblique it. and measure the area specifically there. So here, you go a little bit this way, and it's still getting narrow. So this area is not bad to measure it. So if you could do the same thing, Control P, and try to be zoomed in so you're more confident with your dots. So I'm getting an area of 3, so 3 out of 15. It's going to be 1 out of 5, so 20%. So this is 80% stenosis if you just do the math. So this is 80% anatomically stenotic lesion. So the next step will be, how would you proceed with this patient? Call the cardiologist and ask if they're symptomatic. Proceed with invasive coronary angiography or CT-FFR. So the guidelines, the chest pain guidelines, even the American and British, the cutoff is different, but for you, just to remember, I think a lot of us agree on the 40 up to 90%. I go between 40 to 80, but even 40 to 90% by the guidelines is a valid reason to proceed with CT-FFR. So the decision was to proceed with CT-FFR.